Hello, everyone. Am I audible enough? Can anyone reply back?
Yes, sir.
Okay.
We can hear you.
Okay. Thank you so much. And I will request everyone to mute. And in case of any query, you guys can we can have a good Q&A session at the end of it. So sorry for a delay, because I realized that keeping a two laptop is a bigger headache than keeping a good better laptop, because I had signed in from a Zoom in another laptop and I was opening the another one in which I was preparing the presentation. So let's start with the presentation, and then with the last half an hour we will have a pure discussion in which everyone can speak and we can discuss. So what I'm going to say and or discuss is my perspective as an maxillofacial radiologist for pterygoid planning. So a brief about me. I have done masters in maxillofacial radiology. We run a chain of a diagnostic center, which is as Oroscan. We are like 25 center, and we have a company on 3D printing in which we manufacture 3D models and surgical guides. I did my postgraduate diploma from oral implantology from DY through IGNU, and recently I started exploring TMJ, which is a fascinating field itself. So, what are we going to talk about? First, why pterygoid implants? Second, what are the basic clinical anatomy? Third, radio anatomy. Fourth, a theory of triangle for a safe pterygoid planning, which is something which I came across while I was planning for many cases, that why it is being considered such a dilemma about pterygoid, that why pterygoid करना है मुझे नहीं करना है, it is difficult. देखो ना कोई पीछे एक छोटा सा implant जा सकता है क्या? Why such an enigma for it? And finally the Q&A. So now this is something which we came across in most of the time, is a pneumatized maxillary sinus. We don't have bone in the in the 6 and 7 region. We are supposed to place a tilted implant into the premolar region, and then there is an pterygoid and tuberosity implant region, which is there, which is unexplored and something which we are very afraid of. Now, why should we do pterygoid implants? This is something you guys better know than me, because I suppose that people who have entered are all implantologists. So we want to avoid an cantilever. So why not use something if it is given by God and utilize it to its optimal level? But is there any scientific literature or is there any science behind why pterygoid was considered? Why it was not used earlier? Now, why all on four was concept was started because of two things. One, by tilting we are increasing our AP spread, and second, the bone near the sinus region was more mineralized, so there were high possibilities of getting an good anchorage. So that's why a tilted was planned in the premolar region. But when we talk about the tuberosity, we all have studied tuberosity has the most porous bone. It's D4, D3 bone most of the time. Then how can we place in tuberosity region? Then came the concept of pterygoid implants. So first, as I told you that it is a low bone availability, which is the first reason why we wanted to go for an pterygoid implant. Second, maxilla is the most porous bone. So we have very less site, which is more cortical, which can give us an good encourage or good torque for going for immediate implantology. And third, what other option do we have? Sinus lifts, grafting. Now, it is not wrong. It is in good science, sinus lift, but is it as predictable? No. It is something which we are putting into the body and we don't know the predictability, whether it will ossify with the natural bone, yes or no, we don't know. So that is something a big question. Second, our patients have lost patience. Our patients are coming with that we want results immediately. So how to deal with such patients? So pterygoid implants is a good solution when we have such cases. Sorry. Okay. Now, next thing is, what is so good about tuberosity region? Just a minute. Uh, you know, I'm sorry for again pausing it because I just got a call that someone wanted to register. Okay, I was happy, but I told no. I can let someone time get wasted. Okay, coming to that. What is so good about the tuberosity region and the pterygoid implants? Now, just see, you all have seen the maxilla over here. Now, this is an axial section. This is from the posterior part and this is from the lateral part. Now, I want you to remember only three things. One, maxillary tuberosity, which you can see it on the right hand side. Second, the pterygoid plates. And third, there is a triangular bone of which is a continuation of the palatine bone, which merges the tuberosity and the pterygoid plates. Okay. So I'm coming again. Remember three things. One, tuberosity bone. Second, pterygoid plates, which are part of the sphenoid bone. Third, a bone, a triangular bone, which fuses the tuberosity and the pterygoid plates. So remember these bone. Now, another important thing I want you to remember is all three of them, when they are fusing, they form a most dense part of the junction, which is called pterygomaxillary part. Now, this is a combination of all three bones: the sphenoid bone, pterygoid plates bone part, the triangular part of the palatine bone, and the tuberosity. All three fuses to form a vertical bone, which is a most dense part of the maxilla. Why I'm emphasizing it, that I will tell you in the subsequent slides. Coming back, as I told you, when I see it from the above, you can see the horizontal part of the palatine bone, which is, you can see a greenish part, which is an extension, which I told the triangular part. But I don't want you to remember that for the slides. I want you to remember the two holes which are seen, the greater palatine foramen and the lesser palatine foramen. Why I'm showing you this color images? Because later on there are all gray images. You will be able to see what you can see it on the OPG. You will be able to see what you have to see on the CBCT. So I want you to understand how it appears on a clinical scenario. So important vital structures over here are the greater palatine foramen and the lesser palatine foramen. Now, would you say that does it come in our path while placing the pterygoid implants? No, it doesn't. But what if you have that day when your pterygoid implant doesn't hit the site where you want? Then when it is going towards the palatal, lateropalatal side, it might hit these vessels. So you need to be aware about these vessels. The next important thing is, are there any life-threatening vessels present over there? Yes, there are, but they are in the slightly superior place. So again, I want you to remember here two things: pterygopalatine canal and pterygoid plexus. These plexus, when injured, can lead to life-threatening bleeding. So again, I'm just going back. I want you to remember three things. One is the greater palatine foramen, lesser palatine foramen, which where it is present on the palatal side. And the next is pterygopalatine canal and pterygoid plexus. Again, this we will see where they are found on the radiograph, but I want you to remember they are slightly above. This, the junction which I told you, the most dense part, this canal is exactly above it. So in case you are placing an implant too far superior, you might hit this thing. But again, we will see it on the radiograph. But I want you to remember all these things. First, the three part of the bone which you need to remember: tuberosity, the triangle part of the palatine bone, and the pterygoid plates of the sphenoid bone. Now, the pterygoid plates are two, the medial and the lateral. Most of the literature says that you are supposed to engage the medial part of the pterygoid plate, but I am not convinced with it. I will explain you why. And the vital structures which we need to remember are the greater palatine foramen canal, the lesser palatine, the pterygopalatine canal, which has nearby pterygoid plexus. So now, in simpler than literature, I found this too, that there are certain arteries and which are running on the tuberosity and the buccal part of it. But there was little less literature which I could found in support that this will lead to any kind of emergency or complication. But as per Simpleton, there are maxillary artery which is running into the pterygopalatine fossa, which I discussed with you. Descending palatine artery, buccal artery, but buccal artery is present in along the entire buccal mucosa. So I don't know how it can infer our implants, but it's okay. I am supposed to mention everything which is present in literature to you. Now, this is something a big question for my side. Now there are many people who emphasize that your implant should go beyond that dense bone fossa and go and hit into the medial pterygoid plate. Now if it goes and hit the medial pterygoid plate, that site is also the site for the attachment of the pterygoid muscle. Now, this can, some people might say that it's a muscle, it might heal. But what a chronic trauma does to a muscle is that it can lead to reduced mouth opening, and you will never be able to find the cause why it is leading to. So, as per the most of the literature I could read, and as I told you, I will be sharing you most of the good articles which I found, it should go and engage the junction of the pterygoid plates. It shouldn't go beyond. There are people who say it should go to 2 mm beyond. No, there is no scientific data which support that thing that we should do it. Just a minute. Sorry once again. I'm sorry that I can't add anyone else because I want to concentrate on the people who have spared time for me. So I will request anyone not to call and let's continue with this thing. Okay. Now coming back to this, we have understood the pterygoid plate pterygoid muscle attachment, and we are not supposed to go beyond that. Now, we understood the basic anatomy. We understood the vital structure we need to take care of. Now the third is, it's questionable thing. Where is pterygoid? How we are supposed to place, and what our structure will come in between. So let's see what literature says to us. Now the literature says that there are four types of pterygoid posterior maxillary implant. One is into the tuberosity, which is the most porous bone. Second is the tuberosity and the pterygoid process. Third, tuberosity and the triangular process, which I told you, the pyramid process of palatine bone. And fourth is all three of them. So which one to choose? Let's first understand. Now, this is the first scenario. On your right hand side, you can see the implant is totally in the tuberosity region. Okay. Now, is it a good option? Yes, it is a good option. Just because you are having a good tuberosity for a change, you should explore it. Now, the second scenario below that is it is going beyond the tuberosity and engaging the triangle part of the palatine bone. Is it a good option? Definitely, it is a good option because your apical part gets engaged into the dense bone, and which might lead to the good torque. Now, the third scenario just beside it, it is engaging the tuberosity, it is engaging the triangular part of the palatine bone, and it is engaging the pterygoid plates. This is the ideal pterygoid implant. The third image which you can see. Now, the topmost. Now, in this is a very difficult task to achieve, is something you are placing in totally vertical implant and engaging the tuberosity and the pterygoid plates. The pink part is the pterygoid plate, the blue part is the triangular bone, and the yellow part is the tuberosity bone. And now, if you say, is this all right or wrong? No, none of thing is wrong, none of thing is right. But when we say a typical pterygoid implant, so it should go and attach to the pterygoid. So the last one is, which is engaging all three part of the bone, is an ideal situation in which all three part of the bones are getting engaged. That is an ideal scenario. But does anatomy permit us every time? Maybe or maybe not. And if we have a good tuberosity bone, should we ignore and still go and engage the pterygoid plate? It depends whether you want to go for an immediate implant placements or not, whether you want to go for an immediate processes or not. In case you want to go for an immediate processes, you need a good torque which needs to be received from the implant. In that scenario, you need a pterygoid engagement. So you need all three of them to be engaged. Now, okay. The other scenario. Now, the other literature says, which is a little gutsy step to be taken, it's what if the sinus is too much pneumatized? So, what is an option? Now, in all three of them, all four of the scenario, the option stays the same, that you need to go and engage the pterygoid plate junction. But in this scenario, they say that in one case, you are just kissing the sinus lining. In the other case, you are going bypassing the sinus lining. In other case, you are going trans sinus linings. I'm not sure about trans sinus approach because I feel that it is a little a blind space in which we are playing. Because most of the time when we have explored through surgical guide, we haven't succeeded to engage the trans sinus thing because it's an empty hole in which you are just drilling. You might hit and you might not hit A. B, you might hit after 15 or 20 trials. So if that is a necessity, then you should. And the second thing is about the prognosis or the future longevity of such implants is again a questionable thing. Because the literature do say that they are successful, and there are literature which says that their survival rate is little less. But people do it and people do it nicely. I don't have such exposure to such kind of placement. Now, what is an ideal place where a pterygoid implant should go and engage? The ideal place, as I told you, is the junction where all three bones go and meet. It is called the pterygomaxillary junction. That is where and ideally it should go and hit. Where it will hit, you will get the higher torque because of its high density. Now, the first image you have seen, if I take a CBCT of this image, what I can see, the marked area is your junction area. This is just to make your mind correlate with it. We will deeply study this thing, but just to make you starting correlating with a natural clinical anatomy and radio anatomy. The junction is what I have marked over here. The second, same junction, when I see it from the side, the same junction, when I see it from the side, is something which I've showed. This vertical line which I marked is your pterygomaxillary junction, the point where your implant is supposed to go and hit. Now, this is a very important image for you to see and understand. You can see a black colored triangle, inverted triangle, which is there above the white line which I marked. What is that? Can anyone tell me what is that? Is it important for us, or it's just a structure? It's just a structure, or is there anything significant?
It's a
So that
modularity
structure
process.
is pterygomaxillary fissure, and this is pterygomaxillary fissure. Along with that, just beside it is the pterygomaxillary fossa. Now, this fossa is very important for us because from here the pterygoid plexus passes, and this is where if you hit, you are going to have a possibility, something which you need to avoid it, a complication. Now, this is what I told you, that it is the junction of the three bone. But what I want you to see and read is the last line. This junction present a very dense cortical bone of around 602 to 9 to 661 density value, which aids in providing a great stability and anchorage to the implant. So this is why a pterygoid implants are considered for immediate implantology. This image which you have seen earlier, I'm just again emphasizing the green part behind the tuberosity and the pterygoid plates. That junction point is something which we need to hit. Now, is there any other landmark which we need to consider while planning the pterygoid implants? Is there anything which can help us in planning pterygoid implants? I want you to remember two different things over here. First, the important thing is the distal lining of the maxillary sinus. Now, the distal lining of the maxillary sinus will decide the angulation of your pterygoid implant. How steep it is, because more pneumatized and more steep it is, less space for you it is there, more vertical your implant would be placed. Now, this is something which is supposed to be taken care in two scenarios. One, prosthetically, will it be viable? Because all this thing is something radiograph, but in the oral cavity, it is a task to manage a pterygoid implant prosthetically. Second part is, where is an ideal emergence of the pterygoid implant? Like in the left hand side of your image, you will see it will come into the third molar region or slightly even behind it. But on the right hand side, it is way far ahead, which is an ideal location. So as per the literature and as per the prosthetic thing, even the Journal of Prosthodontics suggested that its emergence should be ideally near the second molar or the first molar region. But that is a task. That is really a task to have such long implants. So most of the time it comes near the second molar region. The third, this is something which I've already discussed, that sinus lining. Follow the trajectory of the sinus lining. If you follow, you can safely place your implant. Again, there are two, as I told you, there are two aspects. प्लेस करने के लिए प्लेस करना है कि उसको ऑप्टिमली प्लेस करना है कि इसको प्रोस्थेटिकली भी यूज कर. Now this is something which we have placed, but how prosthetically it will be viable is something which we need to understand. Now I want you to start focusing now on the radiological aspect. Till now I have told you the gross story about the pterygoid implants. Now you need to focus it on that how can you plan pterygoid implants. So before we start, there will be one case which I would request you to take a photograph of it, and you need to plan it and send it to the chat box. Okay, first I will tell you how you need to plan it, and when that OPG comes, which you have to plan, everyone needs to take a photograph. You can go and plan it as I tell you and send it into the chat box. Okay. Now this is a scenario, right maxillary region. Now this right maxillary region, posterior region, you could say that we can place two vertical implants. Yes, you can. But in this scenario, there is a possibility of a third molar which is present down, which will be used into your prosthesis. So you can rehab with a 6 and a 7 going and engaging into the pterygoid place, because you can see it in the 7 region, there is a large reduced density area, could be an extraction socket. So how should we start? First of all, let's mark the normal landmark which we need to consider while placing in pterygoid implants. This is what? This is a tuberosity region. Okay, check A. I told you there are three parts which we need to remember. This is part A. Then B. I told you there is a triangular part of the palatine bone. So I marked the triangular part. Now, in this case, I can, since I'm a radiologist, so I can help you suggest with, in case you are sure whether you want to put in pterygoid implants, you can also take an OPG with making the patient mouth open as much as possible. In this scenario, what will happen is your coronoid process shadow won't come in between and make it difficult for you to read. Since I see these images day in day out, so it is for easy for me to read it. but it might be little difficult for you. So that is something you can try it. Now, the third part is the pterygoid plates. Now we understood, we saw the tuberosity, we saw the triangular part of it, and then the third part is the pterygoid plates. Now, that is something which we have understood. Now, where we are supposed to place implant? Now, you need to draw two lines. The first line is your alveolar plane, alveolar bone plane. That is your horizontal line. Now, the second line which you need to remember is the end of the pterygoid tuberosity region, and draw a perpendicular line above it, which you can see a single linear line going there. Now, this is the most important thing which you need to remember, which I call the theory of triangle. Because if you can mark this thing, this two bisector in a proper way, you have win the race. Now you can, again, I will tell you, the horizontal line is the alveolar bone, and the vertical line is the end of the tuberosity going up and hitting the junction of all three bones. Now, what is the theory? The theory is this triangle which is formed is an ideal place for you to place your pterygoid implants, because this will go directly hit into your junction, the place where you want all three bones go and meet. This is where you will go and hit. So considering this triangle, I can place my implant over here. Now you can see that it goes and directly hit the junction of all three bones. This is the same triangle which I've shown. You can see it over here. I go it back. Triangle, same triangle you have to hit. Now, this is something which I want you to try, because this is very easy. I've emphasized a lot. Three bone to remember, mark three bone. Second is junction, make two perpendicular lines. One is the horizontal along the alveolar bone, going till the end of the bone, tuberosity, and a vertical line going and hitting the junction. Now I want, you can see this is what I showed to you. Now I want you to try. So I will give you 5 minutes. No, I will give you 7 minutes for you to give it a shot, that whether you can plan it properly or not. So here is your case. Let's try. On the right hand side, I will keep on telling you what you need to do. First, you need to go take a picture of it. Then you can go and edit into any kind of editor, or even you can go to an Instagram, upload it into the story, and you can, there is a marker over there. So before I start, before you start, can you tell me, would you be able to do it? Yes or no? I need a answer yes or no in your chat box. Otherwise, it's a waste of time. Whether you would be able to do it? Anyone in the yes? Okay, I'm getting good yes. Let's try it. Let's try it. We have time. We have good amount of time, because this is just OPG. CBCT, after this, there will be a CBCT, which will be more things to learn. So let's start with the basic things. I want everyone to take a screenshot, take a photograph and plan it. We have 7 minutes, and then you can share it into the chat box. And I will do the planning also in this, and I've already done it, so I will do it. First, take a picture. Second, in case you are not able to demarcate, then first demarcate the tuberosity. Second, demarcate the pterygoid part, the palatine part of the, the pyramid part of the palatine bone. And third, the pterygoid part of the sphenoid bone. if you are able to see a junction, a small linear radiolucency going up with a inverted triangle, which you have to avoid. That inverted triangle is a danger. You don't need to go there. So till there is your safe zone. From there, you are supposed to prepare two bisectors. One is an horizontal line which will be along the alveolar bone going till the back, and from there a vertical line along the fissure. That triangle is your safe bone. So another 6 minutes to go. We have 6 minutes, and I will patiently wait for you guys. And I want everyone to give it a try, because this is the most necessary part for you, because you might be in the consultation where CBCT might not be available. Excellent, I've got it from Sabi. Super, super. I've got another. Let me download and see. Okay, good enough, good enough. Okay, another. The two of them. Okay, I'm going into the right path. You guys are understanding. It's great to see that. I'm waiting for other people. In case anyone is in doubt, you can see these guys have already done it into the chat box. You can have a look. We still have another 4 minutes. We have good period of time. No, it's in blank image. Yes, but it's perfect, Dr. Neetu. You are gonna step ahead and did a wonderful job. Still waiting for others. I'm still waiting for, we have another 3 minutes to go. Should I wait? Okay, yes. Dr. Isha has sent something. I'm not able to see. It's a time. Dr. Isha has sent me my only OPG image. I'm not able to see in case you have done anything. Perfect. So there are people. Okay, someone has even planned for the mandibular region. Great. But we are supposed to talk about only pterygoid implants. Super. Perfect. So I'm so happy to see everyone is participating, and thank you so much. So I guess few of them are left, or I guess suppose almost everyone has done it. Okay, let me show how I planned it. Okay. So I personally like to zoom it, because that gives me a detailing about it in case I'm missing any vital structure or something. This is what I have planned, and I see one or two structures, one or two people who are very closely with closely towards my planning. Am I wrong or you are right? It's not like that, because this same implant can be still placed more vertically because we still have the bone above this placed plant implant. But I like to stay away from the sinus lining, so I did it, but you can still place slightly more vertical. Now, why this is something which you need to, now the other side of something which you need to, I want now coming everyone to come back to this and see the slides in. The important thing over here is more steeper the implant, more might be more difficult for you to rehab. Now the something which I have planned will require a multi-unit which is up to 55 degree, and there are not many companies which is having such a multi-unit. So this is something, I'm not an prosthodontist, but I can give you a faint idea what difficulties I face. So this is something which you need to consider while you are planning thing also, that you were one of person is more uprighted the implant, might be prosthetically that would be much better than what I have planned. But what I wanted you to show, you all guys have understood the three bones, the theory of triangle. You guys have perfectly understood. And now let's go ahead. Now let's understand things on CBCT. Now, since you all are aware about the medical legal analysis or medical legal things which are going on now, so now it would be a necessity to do a CBCT and planning and everything in future, because you can't escape the thing that, okay, I thought that I would be able to do it and I couldn't do it. So the patient will say, why didn't you go for a higher investigation? Because I thought that I will be able to do it. No, this is not the answer we can give it to the patients. So let's now understand the other aspect of the thing, which is the 3D aspect. Now I'm going to show you the videos. Okay, everything is video based for the 3D, because it would be difficult for me to operate and at the simultaneously talk. So I have recorded the videos for you. Now let's understand the basic anatomy. Again, going back, this is a 3D image. Now we all say that, and even the literature say that in case you are confused on a radiograph, print a 3D model and plan it on it. Now, if you say कि सर प्लान है, इस पे प्लान तो कर लेना, पर ये तो बोन है, मेरे को तो क्लिनिकल सिनेरियो में सॉफ्ट टिश्यू के थ्रू डालना है, and in which I'm not going to raise the flap. Otherwise, the entire thing goes little late. I'm going for an immediate implant, so I can't go with the flap. So what you can do is you can ask your CBCT person to take a CBCT with a blowing air in the mouth, like this. And with this, at least we can do is we can prepare a model for you which has the soft tissue layering above this also. So when we give it to you, it has it has the model with the bone and the soft tissue. But that is not in compulsion if you get an idea, because angulation won't change with it. The angulation is not going to change with it. It is only that how close you want to go to the clinical scenario. That's the reason. Otherwise, the planning doesn't require a soft tissue thing, because everything you can get it from the CBCT. Now let's understand this CBC in this video. Now, this is something which you need to see. This is your maxilla. Now, in this maxilla, we have understood all three parts. This tuberosity bone. Now, second is the palatine bone going its wing into and form a pyramidal bone, and then is a pterygoid plates. These pterygoid plates, one is the medial and other is the lateral. Now, that fossa, the junction is where you are supposed to go and hit. So when you are doing a virtual planning, you will more be used to this kind of 3D reconstruction, which can help you because you are clinically well oriented. This is something I will give you a tip, that plan it on the software. It will give you more visualization and it will make you more easy in the clinical scenario. Now, the second video. Important structures. Important structures, as we discussed, are two. You can see it over here, the two holes. I'm just zooming it. The two holes, the greater palatine vessels and both the side bilaterally and slightly posterior to it would be the lesser palatine, which would be smaller in size. Now, always understand that we are taught that कि आपको जब डायरेक्ट करना है बक्कल से जाना है towards the palatal side, but it is not too far palatal that it goes and hit the vessel. It should be within your crest, but the direction has to be buccal to palatal. You can see if I come from the buccal, I will go and directly hit it over here. Now, this is the vessel which I have marked. I suppose if you are more good with 3D, you can do it. It will help you better plan it. And this is the extension which if we go, it goes into the fossa and it becomes little difficult if we are skipping this. Now, what is the basic CBCT of reading? Now you need to understand that CBCT shows three structures. The images in three ways. One is the coronal, axial, and the sagittal. दिस इज एन एक्सेल व्यू, आई कॉल इट अ बर्ड्स व्यू. अब इस बर्ड्स व्यू में आपको क्या दिखना है, हाउ थिक इज द जंक्शन. वो जो तीन बोन का जंक्शन है वो कितना थिक है. सेकंड, वाइटल स्ट्रक्चर वो कौन सी डायरेक्शन में, टूवर्ड्स मिड लाइन है, टूवर्ड्स एक्सट्रीम बीच में है. यू कैन सी इट ऑन द लेफ्ट हैंड साइड. This is the vital structure I'm showing to you. Now, these vital structure needs to be remembered while you are placing the implants. This is not to threaten you, but you should be aware what all things you need to consider while you are. कि ये vital structure बहुत बड़ा है, किसी में hypertrophied है, तो then you have to consider the pterygoid plates. Are these short? Are these broad? Are the thickness over this in the thickness of the pterygoid region is adequate enough? In which plane it is adequate, whether it is slightly above, slightly lower. So all these things you need to consider. Now, the second thing which you need to understand is the sagittal section. I call it the side section. This side section will be a similar image of your OPG which you have planned, and it's actually the most ideal image. This is the inverted triangle and the small fissures which are going down. Now, as I go to, these are the vital structure, the greater palatine canal going upstairs, going into the major vessels, and just beside it, on it would be on the lesser palatine. Now, remember, these structures are present medially and palatally. So ideally, if you are staying within your bone, you are never going to hit it. But somehow, if you got it ambitious and you are going for and you are not getting a torque and you are going like this, and then you will go and hit. Otherwise, most of the time, it is not coming in your path. And the third thing is, again, if you are following the theory of triangle, you don't really need to think about the pterygoid plexus because it will never be in your path. See, I'm just drawing that vertical bisector and then the horizontal bisector. This is again the same thing which you have learned on the OPG. You will do it in the same way. Now, the good part over here is, if I'm having any oral surgeon within this chat, is something, in case you are concerned that I'm supposed to raise the flap because I want to see the bone and do it, because many oral surgeons are like, no, I want to see the bone. It's okay. But how can you help with this? Now, what you can do it is in this, when you are doing the virtual implant planning, you can actually measure the angle. Okay. When you measure the angle, the same angle measurement with a protractor or as something instrument, and the same thing which you can use sterilized and use it in the clinical scenario and mark it on the buccal side. This gives you an orientation in which direction you are going. But again, all these things is to be getting more conscious most of the scenario, if you know how posteriorly, how superior you want to go, and you go in that direction, in most of the time you are in the safe zone. The triangle is the safe zone. You just need to remember the triangle and replicate it in the clinical scenario. Now, the implant planning. There is nothing which I'm going to extraordinary show it right now in the implant planning, which you now already know. But I will just show you few tips and tricks. Now, this is the same case in which we are going to do the implant planning. So, what I will do is I will go first into that region. I will just explore that region. Okay, no vital structure. The bone density appears to be adequate. This is my vital structure, which is on the medial and the palatal side. I've seen it. These are my lesser palatine vessels. I've seen it. Now I will just mark it if I want to mark it. And then I will do the next step after assessing this. What would be my next step? My next step would be to mark. I will mark my alveolar bone. I will mark my vertical part, which will go and hit the junction. And my triangle is ready. And this is the triangle where I'm supposed to plan my implant, the triangle. Now the next step is to do the implant planning. Now we all know the pterygoid implants were most commonly used was the Norris implant. It comes in the wide range. You can see I've planned an implant. I've given a multi-unit. Now there are many literatures which gives two ideas which I want to share it. I will pause it. Sure. Sorry. I will just explain to you is one theory I read it in the article suggested that 45 degree is an ideal angle for pterygoid implants, which is not every time achievable. So you can't give it a goal map that 45 degree is something which you have to achieve anyhow. It will always depend upon the morphology which you will get, but ideal is as per them is 45 degree because of the prosthetic components and the ease of it. And the second thing is, most of the time you need to understand is there would be an immediate extraction case. Now immediate extraction case, you need to see that the tuberosity bone would be even less denser. So in that scenario, you need to be very good in assessing that what direction. Most of the time, people try to follow the socket of 7. Now in this, you need to understand is socket comes in the path of the implant. It is your implant is not going within the socket. So most of the time I have seen in the guided surgery cases is that we did the osteotomy, but while he is placing the implant, he is going for a free hand. Now, when he is going for a free hand, rather than going towards the tuberous region, he will go into the socket region. And you will see, oh, I got the talk. Yeah, obviously you got the talk. You go and you got and engage the palatal cortex, but you are not into the pterygoid place. So that is something you need to see. Now you can see as soon as I've done the virtual planning, I've engaged the multi-unit of 45 degree, I'm getting a perfect emergence. Without multi-unit, it would be most at a 45 degree, but as soon as I use the multi-unit, it is much better and more prosthetically rehabable. And everything this should be done prior to the surgery. Everything should be planned prior to the surgery to make your life much easy. When you are doing your cases, you should be having a pre-plan. Now, the another thing which you can also do is, well, as I told you, there is a technique of blowing air into the mouth and taking a CBCT, which will help you in another advantage is it will give you a soft tissue profile, that what thickness of soft tissue you need to order the multi-unit with gingival height. So that is something also you should try. And all these things which are going to help you in the scenario while planning and during execution. Now I can see See, this is the coronal section. Your implant is into the dead center, going and hitting the junction. But if it goes slightly mesial, it's going to the vessel. Now, in the axial section, you can see that straight going hitting the junction of the pterygoid plates, passing to the palatine bone and going hitting to the junction of it. See again on the sagittal section, this is the best image you can get it, following the path of the maxillary sinus, going and hitting the junction away from the inverted triangle, which is a danger part, and going and hitting the most dense part of the pterygomaxillary junction. This is the theory of the triangle. If you follow, in 99% of the chances, the theory of the triangle, you won't be able to you will be able to do in most of the cases. So yeah, I just concluded with this presentation, but I feel that I wanted to purposefully keep a small session of question and answer in which we can discuss it. Okay, what all things you want to ask to me, we can have a Q&A. So uh, this is a small, let's talk on it. In case anyone has any doubt or any case someone wants to discuss, we can discuss it. Anyone in the group, any doubts? Anything which you want me to again revise also can be done. Anyone,
Good
any
afternoon,
doubt?
sir.
Good afternoon.
Sir, whether there is any difference whether we are preferring basal implant or conventional implant, if any change is there regarding the placement, that the tip of the implant should engage where or like that.
See, in this scenario, I've done more than 500 or 600 basal implant cases with planning. So most of the time things I've heard is that they believe in perforating the cortex and going beyond the cortex. I've never heard the same thing with conventional immediate cases. In basal, I've heard they wanted to go 2 mm beyond, and I am not in that favor because I have done those cases which go and just engage the cortex. They don't go beyond it. There are vital structures, as I told you, if you go and hit beyond the fossa, there is a pterygoid muscle attachment. And no basal person has gone and explained the complications of basal implants. Why not? Why don't it should be shared also? So I have seen cases, 2 or 3 cases. One was into the mandibular region where 2 implants were placed too close to each other, and the patient had an osteomyelitis. Second is was a doctor trying to get more torque. His implant slipped beyond the pterygoid fossa into the infratemporal space. So I would still say that stick to the basics. Go and hit the pterygoid plates or junction. 99, you are engaging the most dense part of the maxilla. You are supposed to get the torque. And that's it. Second is the polished collar. The second difference. Now the scenario in which, as I told you, there are many extraction sockets. Now in Norris has a polished collar, but the polished collar is not that extensive as the basal implant polished collar is. So on those scenario, you need to consider this thing case which you are dealing with. Whether I need a huge space, huge implant with a polished collar, then yes, go for basal. But in that scenario, because a rough surface will get any kind of contamination or food lodgement and things won't be that great. So in that scenario, you need to consider basal. So for me, these two things are need to consider. I hope I made it clear.
Yes, sir. Thank you, sir.
The another question I have got is ideally what is the length and width of the pterygoid implants like minimum? See, now in this scenario, when you are supposed to engage, I would suggest a simple science for you, simple max. Simple max is I'm supposed to start from the second molar, going towards the tuberosity, bypass, engaging the pyramid part and going and hitting the junction. This entire length, whatever the length, should be your ideal length of the implant. ठीक है, क्योंकि इतना तो आपको engage करना ही है. So in that scenario, they suggested, as per Norris, the minimum starting length is 16 mm. First thing. Second thing is, the second is the diameter. Now that bone is porous bone. आपका bone है ना, वहां पे वो तो बहुत ही porous होगा, जाके apically आपको अच्छा bone मिलने वाला है. तो जो आपके implants वगैरह रहते हैं, those are wider, but at the apical thing you would see they are getting narrow and with sharp. So the minimum is 4, I suppose 4 या 4.2 से start होता है, and 16 mm is the minimum length. That is suppose you are supposed to order it if you are available. But again second scenario is कि आप ना सिर्फ ना tuberosity region में implant place करने वाले हो, क्योंकि आपको सिर्फ वहां पे implant डालना है अपने prosthesis के लिए, and you are getting a tuberous good amount of, तो आप normal conventional implant की तरह उसको deal करेंगे. Second is basal implants. Now basal implants you need to consider also the length of the soft tissue, क्योंकि आपका सिर्फ abutment बाहर आता है. So while you are calculating the length, it is from the collar till the apex of the implant. तो वो सारी length आपको calculate करनी. So whatever length I told you from the second molar region, tuberosity and वगैरह, उसमें soft tissue का length add करके, that is the length which you are supposed to go for the basal implants. Okay, there is one more question. How to determine width, which I told you. See, determining width of the CBC pterygoid implant is same as in conventional implant. आपको measurements करके दिया जाएगा, आपको same से वो measure वो width आपको लेनी है. Most of the time the minimum you need to go is 4 or 4.2. What is considered the maximum vertical location in the pterygoid region based on 45 degree? 45 degree is considered to be an ideal. Now, I want you to see, earlier the theory they suggested that when you are placing an Frankfurt plane parallel to the ground floor, इसके 45 degree पे आप implant डालोगे तो you will go and hit. This 45 degree is something, a vertical angulation you need to. So everyone is talking about the ideal angulation. You can never get an ideal case in your practice. There is nothing called ideal. See, always every time your patients when they are coming to you will be having an उसके पास है ना perfectly healed region ही आएगी. आपके पास multiple extraction sockets वाले आएंगे, और coincidentally the God is kind to you, तो आपके पास है ना वो केस आएगा जिसमें आप है ना angulation follow करेंगे. As I told you, simple rule: take a protractor or a bisector, go and measure it, or you can do it on the digitally in the software also. Just measure the angulation. While doing the virtual planning, you will automatically get to angulation, but the ideal is 45 degree. Any other question?
Hello.
Hello.
Good afternoon, sir.
Yeah, please tell me.
Sir, the most important problem what I face during placing pterygoid implant is, even if we do all the planning on the CBCT and we have determined the angulation, everything we have determined. But while doing the placement, that making a 3D view, and then during the placement, we do not know exactly where is the medial and lateral pterygoid plate. So is there any tips or tricks what you can tell that we can little bit determine the position in the mouth also?
Yeah, so in this clinically, and I had read an article which I will share it with you, hemular notch. The hemular notch, which is the comma shaped structure which is just behind the tuberosity. अब वो junction पे आप tip कर पे रखोगे ना, so you will get an idea that what junction you are supposed to go and hit. But when you are again coming to that part of it, can a medial or lateral pterygoid, I am not in that favor that you have to perforate the fossa and go and hit the medial pterygoid. That is something which I don't personally feel the significance. That is something they want to advocate is bicortical engagement. Cortex, एक cortex से जाके दूसरे cortex को आप engage कर रहे हो. But within that structures, you need to consider there are many vital structures which might be passing through it. So I am of that thing. If you are just hitting the junction, pterygomaxillary junction, in most of the scenario, you should get a high torque over there. When we say high torque, and it is a torque enough for you to give a prosthesis. And someone asked me what is the minimum and the maximum angulation you can taken up. It's see the last, if I'm not wrong, the Biolin gives an angulation. If I'm talking about the conventional, क्योंकि basal में तो आपको angulation का कुछ फर्क नहीं है क्योंकि you can bend it from the neck. But the Biolin gives an angulation up to 55 degree. उसका जो multi unit आता है maximum angulation for 55 degree पे आता है. Yes, I have clinical videos. I will share it with you. That the handrail, you can see it. And what we do in the guided surgery is, जो सर को भी एक डाउट था, so जो पूछा था कि while we are placing the implant, in most of the time I'm not able to assess whether I hit it or not. तो हम लोग what we do is that while we are doing a guided surgery, we give you two guides. One is for drilling through the, one guide will allow the drilling part, and the second part would allow the implant placement by the same guide, which will won't have any metal rings, would allow you to place implant and going in the direction. Then why the thing which you are facing the problem is because the tuberosity is the most porous bone. Or you have any extraction socket. In that scenario, you with your the when you are drilling it with, even with a hand drill, it will go with in the least resistance path rather than going into the straight and hitting it. वो आपको hand, you have to be in solid hand while you are directing. Otherwise, it will go into the least resistance path, will be which will be in more towards the palatal side. Measurement starts from, mostly the measurement starts from the second molar region going to the tuberosity end of the tuberosity, second molar till the end of the tuberosity, because as per the literature it is said that your emergence of the pterygoid should be in the second molar region. Any other questions? I would someone would like to ask any question? Yes, we are going to share you the clinical videos also. We have a live surgery, so I will share it with you. How to check clinically that implant placed at the pterygoid junction? See, clinically, the best option is to open a flap and see it. Because even if there is no other way, the best way is radiograph. Of course, radiograph is the best way you can assess that you have probably hit the thing or not. And OPG or IOPA can be done because, but it is a limited view, so आपको visualization नहीं आएगा. OPG से you can best assess whether you have gone and hit the pterygoid junction or not. So it is clinically, you can never rate unless you are raising the flap and seeing it with your visual eyes. How can you can assess it clinically? They say that see, the more the cases you will do, you will feel that कि एक particular direction से मैं जाता हूँ तो I go and hit it, because most of the time we have seen is that when we go and from the buccal side and it goes and hit the junction, because our bone is like more horseshoe shape. It's more horseshoe shape. So when I go it from the buccal side, I will go and engage the mid part of it. That is the only thing I can help you out with clinical scenario. Any other question? How would you, let me ask you a question. How would you assess the density of the bone? Now this is the important thing which you need to that कि आपके पास ये case आया, how would you assess the density of the bone? Anyone?
So we would follow the Leghoman Zob classification for it because HU values are not accurate.
So what you will do?
Leghoman Zob classification.
Okay. Anything else?
And so on the CBCT, we can do the Hounsfield in the HU values that are given in it.
Understood. Now, abhi there is a scenario. Now, this is a scenario. एक मैं trick सा ही बता रहा हूँ. It is not written any book or something. Just to understand the layman type. So we on radiograph we see three colors. One is white, other is gray, and other is black. तो रेडियोग्राफिकली आप तीन कलर देखते हैं, ग्रे, व्हाइट एंड ब्लैक. नाउ इफ दीज थ्री कलर्स का आप ग्रेडियंट डिवाइड करोगे ना D1, D2, D3, D4 में, तो इट स्टार्ट विद अ व्हाइट एंड इट्स एंड विद अ ब्लैक. सो in most of the scenario, when you see a bone, you need to see that what gradient it falls in. You can always go into the grayscale value in CBCT, but if it is a scenario where आपके पास है ना सॉफ्टवेयर नहीं है एक्सेसिबल, आपके पास सिर्फ प्रिंट्स आ गई हैं, आपके हाथ में सिर्फ प्रिंट्स हैं, and you need to assess with it. So you need to see two things. How much is the black component? Because more the black component, more porous the bone is. Second is the trabeculae. बड़े बड़े ट्रेबिकुलाई मैरो स्पेसेस हैं, दैट मींस इट सजेस्ट बड़े मैरो से अगेन इट फॉल्स अंडर द D4 कैटेगरी. Whiter bone, denser bone. Gray bone falls into the D2, D3, in which the trabeculae will be small, and the marrow space would be small. Larger the marrow space, it will fall in D3 and D4. जितना black component ज्यादा होगा, it will be a D4 bone. This is just to make an understanding more easier when you are analyzing a case. कि आपको ना एक डिसीजन लेना है बिफोर प्लानिंग, वेदर आप पेशेंट सामने बैठा है और आपको एक कॉल लेना है कि वेदर आई विल बी एबल टू प्लेस और नॉट. तो गो विद अ ट्राइंगल एंड सेकंड इज द डेंसिटी, वेदर इट इज ग्रे, व्हाइट और ब्लैक. ग्रे, हाँ, ग्रे, व्हाइट और ब्लैक. So more whiter and gray, more better the prognosis, and more density, more good, better the density it would be.
सर अगर कोई कॉम्प्लिकेशन हुआ है तो कैसे मालूम पड़ेगा कि क्लिनिकली कि भाई यहाँ पे टेरिगॉइड इम्प्लांट है? तो
जब आप अपनी डायमेंशन सेट कर दोगे ना, आपको कॉम्प्लिकेशन आएगा ही नहीं. ये कॉम्प्लिकेशन कब आएगा? मैंने बोला आपके तीन ही कॉम्प्लिकेशन, चार नहीं, थ्री. यस, देयर आर थ्री वाइटल स्ट्रक्चर्स फॉर यू. वन इज इन, जो आपके पहले मीडियली और पैलेटली आएंगे, वो क्या है? ग्रेटर पैलेटाइन और लेसर पैलेटाइन. उसको इंजर्ड करा तो आपको प्रोफ्यूज ब्लीडिंग होगी. आपके पैलेट साइड पे आपको हेमरेज जैसा दिखेगा या एक डिस्कलरेशन होगा. सेकंड आपके पास है ना टेरिगॉइड प्लेक्सस, आपने ना मोर वर्टिकल गए, आपके रादर देन फॉलोइंग द साइनस का डिस्टल मार्जिन, आप है ना उसको और सीधा गए, तो आप वो इन्वर्टेड ट्राइंगल में घुस गए. वो इन्वर्टेड ट्राइंगल में क्या प्रॉब्लम है? दैट इज एन, आपका प्लेक्सिस उसके नजदीक होगा. वो प्लेक्सिस में गया तो क्या होगा? इट कुड बी एन इमरजेंसी, अगेन एन इंटरनल ब्लीडिंग, अगेन यू नीड टू सी कहीं पे डिस्कलरेशन है, पेशेंट को डिस्कम्फर्ट है. थर्ड इज द, आपने गए, आपने ना, आपको और टॉर्क नहीं मिला, आपने हाई टॉर्क करने के लिए यू हैव गॉन बियॉन्ड द फोर्सा इनटू द टेरिगॉइड स्पेस, और आपने मसल को इंजर्ड किया. तो पेशेंट 2 या 3 दिन, आपको टॉर्क तो मिल जाएगा, पर 2 या 3 दिन के बाद पेशेंट आपको आएगा कि व्हेन आई एम ओपनिंग आई एम गेटिंग द सॉरनेस, मेरा पूरा मुंह नहीं खुल रहा है. दैट इज, दीज आर द थ्री. अब ये तीनों कॉम्प्लिकेशन को आप है ना अज्यूम करो, ये तीनों कॉम्प्लिकेशन, इज इट अ कॉम्प्लिकेशन which can't be avoided if you stay in the dimension? If you stay in that dimension, you will never face these complications. I am asked that like in implant planning, we give the marking in multiple section. Can we do the same in pterygoid implant planning? Yes, you can. But see, I would suggest pterygoid implant planning में जब आप दे रहे हैं तो आप है ना उनको, I suppose you are a radiologist, तो मैं आपको बोलूंगा even as a clinician I would suggest you ask your radiologist कि मेरे को एक है ना टेरिगॉइड जंक्शन की विथ मेजर करके दे एक, तो वो जंक्शन की विथ जो आपको एक्सियल सेक्शन में मिलेगी। सेकंड, मेरे को एंगल मेजर करके दे, जो मैंने आपको बताया वो ट्राइंगल का एंगल मेजर करके दे, तो आपको वो ट्राइंगल का एंगल पता चलेगा किस डायरेक्शन आपको इम्प्लांट्स डालना है। थर्ड, उससे असेस करवाना है कि मेरे को डेंसिटी उस पार्ट की कैसी है, वो असेस करके दे, वो करके दिखाएं। फोर्थ इज द वाइटल स्ट्रक्चर, इफ ही नोज के वाइटल स्ट्रक्चर्स कहाँ हैं, तो जब वो मार्किंग कर रहा है उसको बोलो कि सिर्फ इंसिसिव कैनाल की मार्किंग मत करके दे, पीछे ग्रेटर पैलेटाइन वेसल्स एंड द लेसर पैलेटाइन वेसल की भी मार्किंग करके दे।
Hello,
हेलो
sir. Can you repeat this what you are told now?
सो आई हैव बीन आस्क्ड दैट कि अगर ये टेरिगॉइड इम्प्लांट्स की मेजरमेंट्स करनी हो तो कैसे कर सकते हैं। सो आई वुड सजेस्ट एज अ क्लिनिशियन यू शुड आस्क योर रेडियोलॉजिस्ट टू गिव यू एक्सियल सेक्शंस। उस एक्सियल सेक्शन में उसको बोलो कि मेरे को टेरिगॉइड जंक्शन की विथ मेजर करके दे। उसको सजाइडल सेक्शन में बोलो कि मेरे को वो ट्राइंगल मार्क करके एंगल मेजर करके दे, बिकॉज दैट एंगल विल शो दैट व्हाट एंगल आपका टेरिगॉइड इम्प्लांट इंसर्ट होना चाहिए। थर्ड, उससे पूछो कि मेरे को वाइटल स्ट्रक्चर्स मार्क करके दे, ग्रेटर पैलेटाइन और लेसर पैलेटाइन, बिकॉज यू आर अवेयर। फोर्थ इज यू नीड टू आस्क हिम अबाउट द डेंसिटी, कि उस पर्टिकुलर एरिया की डेंसिटी कैसा है वो मेरे को असेस करके दे। ये चार चीजें यू शुड आस्क योर रेडियोलॉजिस्ट टू गिव यू on something so that you can keep it handy while you are doing a surgery.
Hello, sir.
Anything else?
Sir,
Anyone?
how can we measure the angle of the pterygoid junction?
एंगल ऑफ टेरिगॉइड जंक्शन का नहीं करोगे, आपको है ना पता है जो मैंने बोला ना, वो ट्राइंगल जो आप पहले
Yes,
बनाते
yes.
बाइसेक्टर, बस वो बाइसेक्टर पे आप वो ट्राई करो कि आपका कहाँ जाके 45 डिग्री एंगल बनता है। वो 45 डिग्री इज योर आइडियल लोकेशन। इज इट नेसेसरी कि आपको वो हर बार 45 डिग्री मिलेगा? नहीं।
Okay.
बट व्हाट इज इन बेस्ट प्लेस जहां पे आप वो ऊपर जाके जाके वहां पे कहीं पे हिट नहीं कर रहे हो, द इन्वर्टेड ट्राइंगल, उसके नीचे आपका कौन सा बेस्ट एंगल बन सकता है वो उसको बोलना है कि वो मेरे को मेजर करके दे।
Okay, sir. Thank you.
सर हैंड प्लेसमेंट करना सही रहेगा कि सर ड्रिलिंग करके सर
डेंसिटी,
टेरिगॉइड?
डेंसिटी D4 गो विथ हैंड, डी D1 तो इम्पॉसिबल है वहां पे मिलना। D2 अगर भगवान आपके ऊपर कृपा कर रहा है और आपको D2 मिल रहा है तो यू कैन ट्राई विथ ये आपको ड्रिलिंग, अदरवाइज D3 D4 गो विथ हैंड।
सर मोस्टली इस पोर्शन के अंदर D3 D4 ही होगा ना?
होगा, यू है सपोज टू गो विथ हैंड। आई सब मोस्ट ऑफ द टाइम मैंने D4 देखा है। और मेरे को मैं बताऊं, देखो आप जब ड्रिल यूज करते हो ना, ड्रिल का जब टॉर्क जाता है तब आपके ना ड्रिल है ना वेवर करती है, आपका हैंड भी वेवर
हाँ,
करता है।
वाइब्रेटिंग।
ठीक है, तो आपका ना एंगुलेशन चेंज होने के पाथ हो जाते हैं। सेकंड, जब आप हैंड यूज करते हो तो सामने आपको एक टेक्टाइल सेंसेशन मिलता है ए, और बी आपको एक रेजिस्टेंस मिलता है क्योंकि आप हाथ से लगा रहे हो, आपके पास कोई मशीन नहीं है विच इज मेकिंग योर ईज। सो यू गेट एन डायरेक्शन, आई एम गोइंग टूवर्ड्स द डेंसर पार्ट ऑफ द बोन, so you get that feeling in your hands. So always yes, the hand driven would be more better. See, these all things which I'm telling you is from my assessment as a radiologist. There might be a surgeon who might find कि नहीं यार मैं तो D3 में भी ड्रिलिंग से कर सकता हूँ, then that is his expertise, not mine. So there are chances that people might be using it. ये तो whatever experience I have working with so many surgeons, I'm just transferring to you. Anyone, anything else? Someone is asking me to share the sample of the CBCT report for pterygoid implants. Okay, I will do it. I will share it with you. Please share the sample. Okay, I will share it with you. Yeah, yes. Okay. Or the people who are asking for me for a CBCT reports, I will share it with you. From that is a report which I prepare it from the clinician's aspect, that what he thinks while he's placing a pterygoid implants, and so I will share it with you, and I will share it with everyone so that they can ask their radiologist to give those things to them while doing pterygoid implants. So that might help you out with in communicating with a pterygoid any radiologist. So I will share it in the group.
Sir, also please share how we can means with you how we can make an surgical guide details of the
Uh,
center.
See, first I can share it only once everyone. I'm going to share one OPG and one CBCT in the group. So everyone is supposed to do the planning as we have discussed and share with me the treatment plan के उस region में आप कैसे, it will be a sectional CBCT. And as soon as I'm getting the right answers, I will keep on sharing them that how we can do a surgical guide. Because why I'm saying it, see, surgical guides is an mean to make your life easy, but that doesn't separate the basics of knowledge you should have while doing the procedure. So I'm more, if I'm doing a surgical guide case with you, I am earning, but I don't want you to face any problems. So I want कि पहले आप एक बार plan करेंगे digitally, I'm going to share you the plans, and उसके बाद I'm going to share you the my side के what all things you needed for the surgical guides and everything. Because I want you to be perfect while you are planning a pterygoid implants radiographically.